Okay.
Sekejap ya.
Second slide.
Okay. An important issue berkaitan dengan pasien yang ada colorectal cancer is the occurrence of synchronous cancer, which are reported, maksudnya kejadian of synchronous cancer tu reported in 2% to 11% of the cases. And then a search for SC, cuba search ni lah synchronous cancer tu lah, is routinely performed during open surgery. Maksudnya dia boleh tentukan pasal SC tu melalui open surgery of colorectal cancer. But intraoperative palpation of the colon can miss up. Maksudnya kalau dia palpation through intraoperative, boleh terjadi miss tu lah something to 69% of the synchronous cancer. Moreover, in the case of laparoscopic approach to colorectal cancer, the surgeon cannot explore the entire colon in a search for simultaneous lesion. Maksudnya melalui laparoscopy, surgeon tu tak boleh tengok keseluruhan kolon tu yang ada simultaneous lesion. So boleh jadi misdiagnosis of synchronous cancer can lead to increased morbidity, kematian, and progression of colorectal to a more advanced stage. Bila dia macam terlepas, boleh jadi kematian ataupun terlepas stage berapa dah patient tu berada. In fact, pre-operative identification of SC implied a more extended colonic resection. Maksudnya, identification melalui pre-op of synchronous cancer is implied into a more extended colonic resection in 11% to 44% of the cancer, because disebabkan pesakit tu undergo pre-op conventional colonoscopy, have fewer local recurrence, ada kurangnya local recurrence, fewer distant metastasis, and longer disease-free survival time. Full pre-op colonic evaluation with colonoscopy should always be performed in patient with CRC. Maksudnya colonoscopy ni mesti dibuat untuk patient yang ada colorectal cancer. Betul ke apa yang aku faham? Okay. Dalam kes yang incomplete colonoscopy due to insuperable stenosing cancer or other causes, endoscopic diagnosis of synchronous lesion may be precluded. Precluded maksudnya apa? Oh, termasuk lah kalau dia buat endoskopi. A recent study
precluded. Panjang ini kau punya perjalanan apa?
Kau baca je masuk.
A recent study showed that advanced neoplasia could be missed in up to 4.3% of patients during incomplete colonoscopy, suggesting that further colonic evaluation is mandatory in these cases. To complete evaluation of the colon, radiological examination can be performed, such as double contrast barium enema and CTC. Untuk complete the evaluation, kita akan sertakan radiologic examination macam double contrast barium enema dan CTC. A multicentric randomized trial comparing diagnostic performance of DCBE and CTC in patient with suspected of CRC clearly showed that diagnostic accuracy of DCBE for CRC is not satisfactory. Maksudnya dibuat DCBE tu not satisfied lagi dia punya diagnostic accuracy. In particular, barium enema missed 12 of 85 cancer. Dalam 85 patient yang ada penyakit, 12 patient tu dah misdiagnosed sebab miss. However, CTC showed a sensitivity for cancer and adenomas larger than 10 mm, comparable to colonoscopy, namely 96.1 and 84% to 92.2%, which is good lah. Moreover, CTC is well tolerated by patient and its complications are exceedingly rare. However, CTC has some limitation. This one is limitation untuk CTC. CTC does not allow the biopsy or removal of discovered lesion, precluding histological diagnosis. Lebih-lebih lagi, its sensitivity for intermediate polyps is lower than that of colonoscopy, namely 70%, and even worse, can reach 48% for diminutive lesion, which is less than 5 mm. In fact, small polyps can be overlooked by pre-op CTC. That is its limitation. Several studies showed that CTC represents a valuable tool to evaluate the proximal colon after incomplete colonoscopy, and the American AGA recognized that CTC is indicated for adult with failed colonoscopy. So kalau adult tu fail in doing the colonoscopy, kita akan perform CTC. Several studies evaluated the role of CTC in patient with CRC and incomplete colonoscopy. In patient with CRC, a CTC with complete colonic distension was achieved in 83% to 100% of the cases. In a series of 174 patients with CRC, McArthur showed that all synchronous cancer and 83.3% of synchronous polyps greater or equal to 10 mm were identified by CTC. Other studies with smaller groups of patients reported that CTC depicted all synchronous cancer and had a sensitivity for polyps greater or equal to 10 mm of 100%. One study showed that CTC is technically feasible and well tolerated also in patients with CRC presenting with acute or subacute bowel obstruction. Finally, a study proved that CTC is a safe and useful method for preoperative examination of the proximal colon after metallic stent placement in patients with acute obstruction caused by cancer. Overall, the above data indicate that CTC, despite its limitation, should be the examination of choice to complete colonic examination after incomplete colonoscopy in patients with CRC, as it is reliably detects synchronous cancer and polyps, allowing surgical removal of cancer or post-operative endoscopic polypectomy.
Asal berapa?
13. Lama lagi.
Lama lagi tak. Kita lagi sikit.
Kita nak boleh habiskan lagi.
Yelah, sikit ini. Berapa minit?
8 minit.
Tumor localization is another significant issue of preoperative workup for CRC, especially in the case of the laparoscopy approach. Laparoscopy surgery for CRC is increasing in clinical practice as it showed comparable results to those open surgery in randomized trials. Maksudnya laparoscopy ni dia lagi banyak digunakan berbanding dengan open surgery. Accurate preoperative localization is fundamental in laparoscopy-assisted colectomy because the colon cannot be palpated during the procedure and the lesion may not be apparent on the serosal surface, adding the risk of removing the wrong colonic segment. Sebab itulah dia buat laparoscopy. Sebab kalau di open surgery kadang-kadang dia tak tunjuk serosal surface tu, jadi dia punya risiko untuk remove colonic segment tu lagi banyak. Dia akan buang tempat yang salah. Precise endoscopic localization of the tumor can be challenging as anatomical landmark may not be readily apparent at colonoscopy, and often only the distance from the anal verge is recorded. The endoscopies can also be confounded by the presence of a redundant colon and atomic variants. In fact, studies shows that colonoscopy has a suboptimal accuracy in locating the tumor, which can be incorrect in 14-21% of the cases, especially in the sigma and descending colon. Sikit lah.
Kayaknya dia tengah bandingkan CTC dengan colonoscopy lah. Betul? Apa macam tadi? CTC dengan
Itu lah laparoscopy.
laparoscopy ke endoskopi?
Colonoscopy kan? Colonoscopy ada accuracy which can be incorrect in
may not be readily apparent at colonoscopy and often Maksudnya dia nak banding colonoscopy dengan laparoscopy ni. So So laparoscopy lebih nampak. But study shows that colonoscopy has an optimal accurate in locating the tumor, which is can be incorrect. 14/21. Other techniques can be used precisely localized colonic lesions such as paramelanoma, endoscopic tattooing, and intraoperative colonoscopy. As DCBE is suboptimal tools can detect CRC, its usefulness for tumor localization is questionable. Moreover, DCBE does not clearly show the position of the various colonic segments in the 3 dimension, leading to potential error, especially in the transverse and sigmoid. Maksudnya DCBE ni paling tak
Kiranya ni adalah
boleh nak localize.
Kiranya ni adalah limitation untuk DCBE tu lah.
Okay. CTC clearly demonstrated that involve colonic segment, the length of tumor extension. CTC tu apa?
CT colonoscopy.
Colonoscopy CT lah kan?
Betul CT.
CT clearly demonstrated the involve colonic segment, the length of tumor pun dia boleh nampak, and its relationship with adjacent organ. Vascular structure pun dia boleh nampak, and peritoneal spaces pun boleh nampak. On 94 patients with CRC, the accuracy of CTC tumor localization was 94.7%. In 65 patients with CRC, the sensitivity and specificity in CTC in determining the location of colonic masses were found to be 100% and 96% respectively, whereas colonoscopy failed to precisely localize in tumor 24% of cases. Cancer staging. Treatment of CRC depend on the preoperative assessment of disease extension. Colorectal carcinoma are clinical stages using the TNM system established by American Joint Committee on Cancer. Table to
Ada 10M of the brain.
Ada tak cakap stand for what?
Tak. 10M tak baca dulu.
Chest and abdominal CT is recommended for the pre-operative staging. Buat chest and abdominal dulu. Pre-op staging of CRC by you.
Kejap, kalau T tu refers to the size yang extend, size lah. And pula refer to number of the lymph nodes yang ada dekat cancer yang dah terbentuk. M tu refers to the if cancer tu boleh merebak ke tak.
Metastasis lah.
Metastasis. Metastasis. T size and nodules. M metastasis. Okay, next.
Okay. Sebelum kita buat kita staging, kita kena buat chest and CT abdominal dulu. Recommend. Okay. Mana dah? Society of Medical Oncology by the American College of Radiology, with the exception of rectal cancer, for which magnetic resonance is more accurate. Okay, staging. Maksudnya semua ni kalau macam carcinoma, colorectal carcinoma, kita biasanya buat CT chest dengan abdominal. Tapi kalau dia ada rectal cancer, kita prefer dia buat magnetic resonance lah, lagi accurate. Although CT is the examination of choice, disappointing results have been reported with staging accuracy ranging from 48% to 77%. CTC potentially represent a comprehensive examination for CRC staging, as it allows for the evaluation of the inner and outer colonic wall, T-stage, pericolonic lymph node, and distant metastasis. Several studies evaluated accuracy of CTC for T and N staging for CRC because CT cannot discriminate the different bowel wall layer. A simplified T staging system has been proposed for CTC reports with a group T1, T2 category for lesion confined to the bowel wall, T3 category for lesion invading subserous fat, and T4 category for cancer invading adjacent organ. To distinguish T1, T2 from T3 cancer, both colonic wall deformity and lesion outer border should be considered, as suggested by Utano as internal wall. Ni semua dia punya lapisan-lapisan kolon dia deformity associated with CRC and observed on SSD reconstruction can be classified into R-type, trapezoid type, and apple core type. R-type is defined as smooth concave. R-type, smooth concave wall deformity. Trapezoid is defined as square-like irregular wall deformity involve less than 50% of the circumference of the lumen. And apple core type is defined as trapezoidal wall deformity involve more than 50% of the circumference of the lumen. The R or trapezoid type is associated with T1 and T2 cancer, whereas the apple core type is associated with T3 and T4. In a series of 4 sick patients with CRC, the third evaluation of wall-shaped deformity as described above showed an overall accuracy for T staging of 79% with a similar classification of deformity and accuracy of 77.6 was reported in another study. Colonial wall outer margin should also be evaluated to distinguish T1, T2 from T3 cancer. Rounded or nodular advancing margin is T2 maksudnya stage lah. Stage 1, stage 2,
so
stage 3
table 3 tu macam kalau T1, tumor tu baru invade this part. Kalau T2 dah invade mana? T3 dah invade mana? Dia macam T size.
Rounded or nodular advancing margin of perivisceral fat considered the expression of T3 stage cancer. The presence of speculation within the fat is not universally considered a sign of pericolonic fat invasion, as speculation can be caused by inflammatory reaction and extramedullary fibrosis. Direct invasion or extent of fat cleavage can cause T4 stage cancer. Using the above mentioned criteria, the overall accuracy of CTC for T staging range from 66% to 95%. Ini juga. Identification of nodule involvement with CT is limited by the use of dimensional and other morphological criteria, such as clustering, in particular as proposed by Philippon. M1 stage can be assumed on CTC if a cluster of 3 nodes is present, independent of their size, or if fewer than 3 lymph nodes are present, with at least one of the node measuring 10 mm or more in the long axis in stage or in the long axis. In stage N2 neoplasm, more than 3 perivisceral lymph nodes are identified, regardless of their size. Using this criteria, the overall accuracy of CTC for end staging range 70% to 85%. Notably, the accuracy of CTC for nodal staging may be unsatisfactory because the presence of regional lymph node metastasis represent an important indication for adjuvant chemotherapy, and up to 30% of node-negative patients eventually develop distant metastasis, possibly as a consequence of lymph node micrometastasis. It has been emphasized that the use of MPR images and in particular of true axial images along the short axis of the colonic segment improve the depiction of the outer margins of the lesion of the relationship with adjacent organ and regional lymph node, leading to more accurate T and N staging. Finally, similar to standard contrast enhanced abdominal CT, CTC and intravenous contrast administration allow for the identification of liver metastasis, retroperitoneal iliac lymph node enlargement, and the presence of peritoneal carcinosis, figure 7. Moreover, scan conducted at the level of the lower pulmonary lobe can identify lung metastasis.
So, for the conclusion, CTC lah is a reliable technique to define the precise set molecularization of the CRC. As siapa yang Izzy cakap tadi, kan dia ada T and M kan. T dia boleh tengok T dia, staging range dia lah 66% to the 95%. Lepas tu kalau N pula 70% to the 85%. So dia macam accurate sangat untuk dia for the precision of the segmental localization of this colorectal cancer. So for example, dah establish the presence of the synchronous cancers, cancer yang berlaku at the same time of the colorectal cancer. Lepas tu polyps yang size dia pula dia boleh accurate lagi for the greater than the 10 mm. Lepas tu and to perform a fairly accurate tumor staging yang ada T1, T2, T3 sampai T4. Lepas tu these factors notwithstanding the CTC has some limitations yang kita dah baca kat atas tadi, including lack of biopsy capability, tengok dia ulang balik. Lepas tu suboptimal sensitivity for synchronous small polyps, maksudnya small from the 10 mm.
Small polyp tak boleh dimasuk.
Tak boleh, macam so limitation dia. Lepas tu unsatisfactory nodal staging. So bearing in mind these limitations, CTC could be employed as a one-stop shop examination for the preoperative assessment in patients with CRC. Dia ulang balik daripada kita punya abstract.
Maksudnya dia ada sampai T1, T2, T3, T4.
T4.
Macam
Ke T6 yang tu?
macam
T4 apa?
macam apa panggil tumor kan.
Tumor.
Tumor.
Ha.
T2 tumor
Tumor,
kan.
betul.
So
Macam
tumor
tu,
ni sampai ada stage 4 kan. Macam cancer stage 1, stage 2, stage 4 mampu.
Betul? Sebab dia punya limitation masuk sampai visceral peritoneum. Kalau
Stage
masuk tu
4 ni,
rosak.
kalau stage 4 ni dia dah masuk organ lain dah.
Betul.
Dia dah masuk peritoneum. Kalau stage 1 dia baru je lining of the tissue colon tu. Kalau stage 2 dia dah masuk muscular, masuk dalam tu. Kalau stage 3 dia dah masuk muscular propria into the subserosa. Lepas tu non-peritoneal tissue masuk stage 4 dia dah pergi organ contohnya hati, hati.
Bang.
Note pun dia juga. Maths pun apa lagi? Okay. Jadi itu saja dari kami. Sekian terima kasih. Wallahualam.